The second main topic is periventricular leukomalacia, hypoxic ischemic encephalopathy. Before we start, I will give a short brief about neonatal hypoxic ischemic brain injury in infants, depending on the severity and timing. If hypoxia occur before 28, may develop hydranencephaly and warencephaly. If between 28 to 32 weeks, likely it will present with germinal matrix hemorrhage. Between 32 to 30 weeks, if it is partial, it will affect the watershed areas, which is the periventricular area in this age. It will present with PVL. If profound hypoxia, it will affect the stellami, cerebellum, and the brainstem, and will spare the basal ganglia and the cortex due to later myelination. If full term, if it's partial, it will affect the watershed areas. If it is acute profound asphyxia, it will affect the basal ganglia and stellami, and also it will affect the cerebral cortex, precentral, and post-central gyri. PVL. It is a white matter injury of prematurity affecting periventricular zones, watershed areas. Etiology ischemia was thought to be the single cause, but infection and vasculitis may play an additional role. Clinical presentation: 50% of setting of cystic PVL develop cerebral palsy, intellectual disability, or visual disturbance. Pathogenesis: hypoxia will impair perfusion and will affect the watershed areas which are located in a periventricular location in this premature infant, and will cause white matter necrosis and then develop cyst formation, later parenchymal loss and enlargement of the ventricles. Grading of PVL. First, PVL presents as areas of increased periventricular echogenicity, and we have grade cystic and non-cystic. Non-cystic, which is grade 1, and persistent more than 7 days. Clinical ultrasound may be normal in patients who go on to develop PVL, and so we have a good protocol is ultrasound examination weekly until discharge all 4 term, as we said before in the screening program. We will start from grade 1. Increases periventricular echogenicity more than 7 days. It is asymmetric. This is larger. This is smaller. Inhomogeneous, coarse, globular, and may be more hyperechoic, may hyperechoic than the choroid plexus. Grade 2 يحصل small periventricular cyst, and the echogenicity has resolved at the time of cyst formation. If cystic PVL on the first day, it is impressive of at least 2 weeks prenatal hypoxic ischemic insult. Grade 3 extensive cysts in the frontal and parietal and occipital lobes. If this cyst reaching to the subcortical areas, it is grade 4. When we talk about PVL, we have to mention flaring. What is flaring? It is the periventricular echogenicity that's seen in the many premature infantis in the first week of life. Is it normal or sign of PVL? First, if flaring persisting more than 7 days, it's considered PVL grade 1. How to differentiate between physiological flaring and PVL? Physiological flaring, echogenicity is bilateral and symmetric, and it's subtle. It is homogeneous. But in PVL grade 1, it is coarse echogenicity, asymmetry, and inhomogeneous globular, and more hyperechoic than the choroid plexus. This is a case of 26 born newborn. We can see bilateral increased periventricular echogenicity. After 14 days, partially cystic formation developed. After 8 weeks, the cysts became more obvious. And this is the MR of 6 week bilateral periventricular cystic changes. What is the differential diagnosis? First, subependymal cyst, germinolytic cyst, post-germinal matrix hemorrhage. Congenital cyst, it is present superior lateral they are present at the superior lateral aspect of the frontal horn and choroid plexus, and parencephalic cysts to communicate with the ventricles and follow luekomalacia. Take home message. First, you have to follow the hygiene protocol before any ultrasound procedure to the neonates. Second, when you are doing ultrasound for preterm, you have to suspect first germinal matrix hemorrhage. If neonate with near full term, you have to suspect PVL. And remember the screening protocol 037 on the first week, twice on the second week and weekly until discharge. This is for high risk. Juvenile matrix hemorrhage and PVL are serious conditions that may develop cerebral palsy, intellectual impairment, so don't miss. You have to remember feeding is bilateral, symmetrical, homogeneous, and not persisting more than 7 days. And it is a physiological. Thank you.